Hello and welcome to the Diagnostics Media Forum hosted by Roche. I'm Genevieve Wu on CNA and I'll be your host for this part of the event. We have a total of 6 speakers lined up for you over 2 expert discussions today. The focus of the first panel discussion is partnering patients and strengthening the patient voice within health systems in the Asia Pacific. Now, most of us have been patients at one time of our lives, for better or for worse, but could the needs of a patient be better addressed in healthcare decision making? Now, to get a better understanding of patient engagement in the region and how different stakeholders can play an effective role, I'm joined by Lance Little, head of Asia Pacific at Roche Diagnostics, and he's been in this role since 2012 when he was appointed as managing director. Lance.
Thanks, Jen. Great to be here.
Thank you. And joining us virtually from Gurugram, India, is Dr. Ratna Devi, immediate past chair of the International Alliance of Patients Organizations, a non-governmental organization focusing on access to health, patient education, and advocacy. Welcome, Dr. Ratna.
Good morning, Jen. A pleasure to be here.
And over in Bangkok, Thailand, we have Dr. Suvanich Triamchanchunchai, who's a cardiologist at not 1, but 2 hospitals at Ramathibodi Hospital and Nakathon Hospital. Hello, Dr. Suvanich.
Sawadee krap. Hi, everybody.
Today, I'm also sharing some of my virtues too, but my duties of asking the questions with you, our virtual audience. Please submit them using the Q&A box below. We'll get our panelists to answer some selected questions over the course of the discussion. Right, now let's move on to the first theme of our topic today, looking at factors that may be posing as barriers to effective patient engagement in the region. Lance, let's start with you. Can you define briefly for us what is patient engagement and how it influences outcomes?
Yeah, thanks, Jen. Let's kind of frame this a little bit first. When we say patient engagement, I think it's important within the healthcare system that we don't suggest that we're handing care over to the patient. But what we are suggesting is that we bring the voice of the patient, in fact, the key stakeholder for everything that we do, into the conversation. So that, to me, that's what patient engagement is framed around. Now, if we want a description, we might say, a patient or future patient, people, us, are interested in, committed to, and have a reliance on a healthcare system that supports them on the long term and on a consistent basis through their journey of life, as opposed to the episodic approach that we take today. Kind of the analogy I always like to look at is finances. I mean, imagine if we spent as much time checking on our health as we do checking on our bank accounts. I think we'd be a much more healthier population.
And how would you rate then patient engagement currently in this region?
It's tremendously variable. If we look right across the region, there's a geographic variation, but there's also a disease area variation. And we need to think about patient engagement, or the healthcare system, I should say, in terms of supply and demand, okay? So we always talk about access and the supply side of the equation. Are there enough doctors, nurses, healthcare professionals, hospitals, etc.? That's the supply side. As we bring the patient voice in, now what we're doing is we're bringing in the demand side. So what is it that the patient needs, and how might we need to shift our thinking around healthcare to satisfy that? And there was a paper published by the Voices Project that looked at what are the elements that we need to consider around patient access around this demand piece, the patient engagement. One, of course, is access and ease of access. Can a person living in a remote part of any country get access to the healthcare system? That's the conversation we're used to. Then there was, the next point which was around trust. So does the patient trust the healthcare system? Now, we saw evidence where, in some cases, trust is very low. We saw this manifest itself within COVID, where we had a lot of misinformation around science and the narratives that were floating around. And then the third piece is the cultural dynamic. So we have to understand that health needs to be delivered in such a way that is culturally appropriate. So the way we deliver health, for example, in Australia or New Zealand, will be and should be very different to the way we may deliver health in Malaysia or China or Thailand, for example. So understanding that cultural element is important. And there was, just to emphasize this, there was a study done in Maharashtra, the state of Mumbai, trying to understand what it would take, or what are the barriers to women, particularly, going for a TB test. And the study showed that 40% of women in Maharashtra would be reluctant to go and get a TB test because they would be concerned, if positive, would they still get the support from their husbands? Now, we can't judge these dynamics, but we have to acknowledge this is the environment that which healthcare is delivered and needs to be delivered. So bringing the voice of the patient in is fundamental if we want to move healthcare systems forward.
Thank you. Now, I'm going to pick up on that point. You talk about access and actually easy access to Dr. Ratna. Now, in terms of accessibility and affordability of healthcare, what are some challenges in your experience in patient engagement in Asia's developing countries?
Thank you, Jen. I think, what drives the demand is awareness that there needs to be something that I invest in as a human being, as a person who probably has the risk factors or is already suffering from a disease. Now, we know that this part of the world, or the Asia-Pacific region, is extremely large, very diverse, both socioeconomically as well as socioculturally. And we also have very disparate health systems. We have a mix of the private and the public sector. Now, the private sector, especially the ones that are advanced, have better instrumentation, they have better infrastructure, they have better trained doctors, and they have better healthcare delivery mechanisms. However, that comes at a cost. The publicly funded systems are more accessible to the very poor populations that reside in this part of the region. But the public health infrastructure is often very underfunded or under-resourced, and there are long waiting times, or quality of care is very compromised since they cannot invest, as governments do not see healthcare as a priority investment in this part of the world. And therefore, patients are often forced to seek the private healthcare institution as out of pocket because they do not get the medicines or the treatment options that they would like. To be able to pay for the private health infrastructure and the resources, one could invest in insurance, but again, there is no trust. And Lance did refer to this. So people don't think that investing in a private insurance is something that will give them benefits later in life. And it is only when they have a crisis that they visit a hospital. So patient populations and caregivers, communities, and families in the Asia-Pacific region do not see preventative healthcare as important and integral. And primary healthcare is very, very weak. So some of the challenges, therefore, are the weak healthcare systems, very large populations with a very big burden of disease, inaccessible private healthcare systems due to cost of care, and not the least is poor health literacy. Therefore, health is not considered the most important thing, and therefore people might invest in a smartphone, but they would not invest in a checkup that could probably help them to understand whether they are at risk to something later in life.
Thank you. That kind of goes to your point, isn't it, about how people would consider more about their finances or a smartphone rather than
exactly.
a health priority.
Yes.
Now, over to Dr. Suvanich. What about, Dr. Rana talked about poor people and their access. What about in Thailand? Do social economic factors play that significant a role in terms of healthcare access and affordability?
Thank you, Jen. Very good questions. I think after the COVID outbreak, economics issue is a major concern for many countries. Our patients with a low income, they cannot access to the hospital or to the healthcare system. Fortunately, in Thailand, we have the Thai Universal Coverage Scheme. This scheme is meant to be, you can easily access to the hospital nearest to you. is funding by the government. So the standard lab, standard treatment, standard medications, you can give it for general treatments, especially when you have the emergency cases, just like stroke, acute myocardial infarctions, or every cardiac arrest. You can go directly to the nearest hospital, and it's for free. It's funding from the government. But because it's free, a lot of the people use this scheme. So it's crowded. A lot of the people is coming to the hospital. The hospital is full of the service. So the people who have the middle class income or the high income, they can pay more with the money for the better treatment to go directly to the private hospital. The gap between the private and the public hospital, they have the gap between them. So in the future, we try to fix this problem to get better healthcare to the system.
Right. Dr. Rana, for you, how do literacy levels or even gender affect the levels of patient engagement in diagnostic care?
So literacy in general in in Asia Pacific is low in many countries, and it is even lesser in the women and young girls. And an outcome of this is that the health literacy is also very low, not only amongst women, but populations in general. And low health literacy means that people are not actively seeking information that is useful to them to be able to manage their healthcare well, whether it is the preventative part of it or managing it once they are diagnosed. So what happens is that people go to a hospital because they are sick or they are unwell, and then they arrive at a diagnosis. And if it was not life-threatening, they simply go back and fall out of the system. If it is life-threatening, they probably have an hospital inpatient care, and they do not have systems that have robust follow-up mechanisms, and therefore they do not again take care of their health, and it becomes a vicious cycle where they are going in and out of hospitals and not really managing their health optimally. As far as gender is concerned, it is a cultural aspect where women are considered the nourishers and the carers, and the men are considered the ones that actually go out and make a living. And therefore, women do not have choices because they are not the people who are given the power to be able to make those decisions in general aspects of their life. And healthcare therefore takes a back seat because healthcare decisions are usually by someone of authority in the house, or sometimes even extended family. So even if there is a crisis for a woman, people are not generally taken to a hospital. They would be offered home health remedies or something that is available close to their home and within their communities, until it becomes so difficult to manage that they are forced to seek healthcare at a modern medical institution. So this kind of thinking and thought process needs a lot of effort, and I think more women becoming patient advocates might add to the benefit of increasing health literacy and bringing health as an important choice that people make on their own, instead of waiting for a crisis to happen before they seek the healthcare that they should have done much before the crisis happened.
Right. So still on the issue of women, of course, being underserved, right, to delve into how to bring about the changes to establish a better patient-centric framework. How can culture then be addressed so that women can engage and take better charge of their health? Dr. Rana.
So there is no easy answer to this, and we see this, in boardrooms, in corporate culture, etc., where women participation is still very low. You see that in science, where school children opting for science is still very low. So I think a lot of investment needs to go where women are made to feel more comfortable coming out of their shells and are able to participate better within communities. I've worked in reproductive health for a very long time, where for 3 or 4 decades, there have been advocacy organizations, there have been governments, and several other national and international institutes that have helped make women better choices about their family planning needs or about their childbearing needs. However, there is still a lot of work that needs to be done, though there is progress. So for areas like, say, breast cancer screening, so that you are detected early enough, or vaccination to prevent, cervical cancer, or even simple tests for blood sugar screening or hypertension, is not going to be easy unless there is a whole of society approach where there is no differentiation between the genders and everyone is offered an equal opportunity. I also think that educating women about their healthcare needs proactively would help, sustain the cause and get more women to come out and do their healthcare screening on time.
Thank you. Lance, my next question to you, apart from equal opportunity Dr. Rana has talked about, let's talk about low health literacy. Now, is that reason enough for adopting what we call the paternalistic versus a patient-centric approach when engaging patients?
Yes, it's an interesting dynamic, this view of a paternalistic delivery of health. In other words, the decisions and control is somehow centrally oriented, and the patient has health done to them, if you like. But I think it's important to understand that whether that's right, wrong, or indifferent, it doesn't matter. The point is, in our different countries, that is the way that health is delivered in many ways. However, I think the problem is exacerbated when you add to that dynamic an element of health illiteracy, and then what you kind of end up with is a passive individual. In other words, somehow imagining that at a point in time, the system will know that I'm unwell and will look after me. And I think that's where we get a little bit of two dynamics clashing, which doesn't give us the outcome that we're looking for. So, but the good thing is, as was touched on earlier, is access to information is far more prevalent today and with a younger generation than it was 10, 15 years ago. So that's fantastic. Now, we need to make sure that we address the education of everybody in an appropriate way with good information. And I think there's sort of two or three elements that drive towards that. So one is integrated health services. So when the patient interacts with a health system, making sure that the multiple stakeholders that are required to deliver health to that patient, and it takes a village, health is complex. So making sure that they are all connected in a way that the information is available in the right time for the right, with the right information to the right person. Yeah. So there's not wastage in the system, if you like. So integrating the health systems rather than a patient going from pillar to post and having to retell their story. Yeah. That's one element. I think the other element is, and I touched on it at the very beginning, how do we get people engaged on an ongoing basis on the narrative of health, rather than just occasionally every 4 years, for example. So that continuous connection with the healthcare system is critically important. And then, of course, finally, the point very specifically to health literacy is education. Understanding that we need to speak a different language. We're very good, and Roche included, we're great in the scientific conversation, but we need to take the learnings that we know from managing disease, and all of us in the healthcare village need to be able to articulate that to the general public, to people, to educate them in such a way that they understand and they connect with it through their cultural context.
Okay, great point. So on the topic of then, I suppose, having to speak a different language or change a different language, Dr. Ratna, how can then the paternalistic model between doctor and patient be changed? Are we talking about this change of language that Lance was referring to?
You know, I'm trained as a physician, and to be honest, I was never told that the patient is an equal partner in healthcare journey. And I think that's what needs to change if this paternalistic attitude has to change. The patient is an equal partner in the decision-making process. Yeah. So the doctor, the patient, and the caregiver, or an extended family if the caregiver is unavailable, have to have a conversation together about what is best for the patient or for the choices that are available, and allow the patient to make their own choice, and then respect that choice and treat the person with dignity and respect. Also talk in the language that patient understands. So very often what is communicated to the patient is not at all understandable, and the patient goes away confused and therefore does not come back or does not follow those instructions. I think bringing an equal platform where both are talking at an equal level and are able to understand each other's language is extremely important. Going back to the reference I made to the, the training and the teaching that happens in medical schools, because doctors are never exposed to what patients think and what they feel or what their needs are. They look at clinical outcomes. So I think it's very important that the patients and healthcare providers work together to be able to make this an easy path. And I do this very often as a person who runs a very large patient organization. I invite patients to medical congresses and doctors to patient congresses. But this is very episodic. It happens one odd time at a congress or at an event. This needs to be institutionalized. People have to really learn. And that institutionalization can happen in several ways. And one thought that comes to my mind is patient organizations like mine can offer fellowships to young medical graduates. They can come and have an exposure. They can sit in forum discussions or patient group discussions and understand what patients really want and what is most important to them. And that really helps them to shape the way that they deliver their care pathways to their patients. I think curriculums can also be changed. That would be a very difficult and very challenging process to take forward. But I believe there is a conversation that has started in that pathway, and all it needs is some kind of investment and commitment from all stakeholders so that it becomes something that the physicians, trust and believe that this is going to help them in the long run.
Dr. Sivanich, I mean, in your experience, is the communication or say the partnership between doctor and patient evolving to encourage better patient engagement?
For my opinion, for many studies, effective communications between doctor and the patients, this can prove that this will improve the health outcomes. So this leading to the patients to understand about their treatment, about their problems. So this is contribute to the patient engagement better. So in my way, I like right now I'm practice about the medicine all the time, every day. I try to be listening to the patients. What is about, listen carefully about their problems. What is their problem? What about their concern? And the other thing, I try to be like their family. Just like I want to be his uncle. I want to be his brother. I want to be his son. And advise them deeply in their heart, in their culture. All the patients, they want to use the herbal medicine. They want to use the new of the medications. I try to convince them, but I don't against them. I let them use it, but use it with the new medication all along together for the better outcome. So I think the communication is very, very, very important. Okay, just like Dr. Anna said before, so in the medical school, they have to be studied and then to help the medical student to know that right now the communication is the best way to communicate with the people. We have to speak in the patient way, not speak in the doctor way, to understand about the communication better between the patient and the doctor.
Thank you. Now, Dr. Ratna, very quickly, how often is patient engagement assessed by gathering feedback from the patients themselves?
So I would say that there are two parts to it. One is, of course, the scientific community that is doing the research, the clinical trials, and other scientific processes. And there, because there is a process and a procedure involved, there is active engagement with patients to collect their feedback, because that feeds into the research and the research outcomes. However, in day-to-day practice, where there are multidisciplinary teams that are required, healthcare is so siloed, and there are so many specialties and subspecialties that doctors don't very often speak with each other, and therefore the patient is moving from one system to another or one specialty to another, and each specialty or each healthcare provider offers a different message, which is sometimes very confusing and contradicting. So a scientific approach to gathering patient information so that they are better engaged in their healthcare delivery, depending upon the touch points that they have in the disease area that they are managing, is still not there or not institutionalized within the health systems of this region. And sometimes it is difficult because you have these multi-speciality large hospitals, you have standalone hospitals, you have physicians who are delivering healthcare on their own as a single specialty. And we do not use digital that much to connect all these patients. We still do not have electronic health records. Much of it is handwritten and sometimes lost. Therefore, I would sum it up by saying patient engagement is still very patchy because the healthcare system is so broken and so siloed. And I think a lot of work that needs to be done hasn't yet started. Some patient organizations are now beginning to see this as a very big challenge that needs address and are trying to bring all these patient groups together so that they are well informed on where to go and where to seek healthcare from. But I believe there is a lot more work that needs to be done in this area.
All right, speaking of a lot more work to be done, Lance, next one for you. In assessment of patient engagement, what are some of the points that must be measured, and what can be done, how can that data be used for patient centricity in diagnostic care?
I agree completely with Dr. Ratner. I think this in particular is an area where a lot of work needs to be done. I'm not sure we've really got a lot of experience and expertise here, but if we think about the drivers that were articulated earlier on, obviously the economics of health have to be considered. We know that in countries where they working through the process of developing a foundational healthcare system with universal healthcare and things like that. As soon as that's been achieved, they then struggle with now how do we pay for this healthcare system? So you can't ignore the economics, and I think somehow a measure around the economic efficiency is important. Again, there was an older study done about 2017 by OECD countries that indicated that there's approximately 20% financial opportunity available within healthcare systems to drive efficiency, right? So imagine what we could do with 20% more effective funding into the healthcare system. So I think the economics is one piece. I think the other piece is around, can we measure the level of integration of healthcare systems? Is there a way in which we can measure that? As a result of perhaps those two elements, can we see and measure a material improvement in the resource availability? There's not a country in the world that I go to, and there's not a hospital system that I go to that is not saying the same thing. We don't have enough specialized people. We don't have enough healthcare professionals. So by driving efficiency through the system, then can we solve some of these problems or take some pressure off some of these problems? And I think the fourth element for me would be actually a measure of healthcare literacy in the general population. If I think about it, this shouldn't be too hard to do. I mean, every time I'm on YouTube looking at the New Zealand rugby team or whatever it is, I get a survey pop up, for example. We can access people now in a way that we could never 10 or 15 years ago. So perhaps we need to be bold and get healthcare on the general daily agenda for everybody and try and get some of this feedback and start working and learning about getting the voice of the patient back in.
All right. Now, so there's data that needs to be collated and analyzed, and there's also changing systems and the way people work. That may require quite a bit of effort, and organizations may not be able to do it alone. Let's take a look at how different stakeholders could be galvanized to stimulate effective patient engagement. So, Dr. Ratner, would patient advocacy groups strengthen patients' voices in the healthcare landscape?
Yes, they most certainly do. And we've seen so many examples where patient groups have got together to move mountains to get medicines as well as diagnostics within their countries. They have come together to pass UN resolutions to accord priority to the disease-specific areas that they are interested in. So patient engagement groups do have a very, very important and very large role to play. And this is some of the global work that I mentioned. But at the country level and at the sub-country level, a lot of patient groups actually do very fundamental work in bringing disease awareness amongst patient groups, helping them to understand the natural history of the disease, and helping them to manage and maintain their condition so that they don't progress into complications. So patient group, to give you a very simple example, if all the hypertension people who were diagnosed with hypertension and are not into any complication simply monitored their status every month and did not give up on their medicines, we would not have so much of a burden on the critical care, which is the hospitals, because there would be no strokes or much fewer strokes than what we see now. However, that's not happening because doctors are busy and health systems are overburdened. And patient organizations and patient groups can come in and play a very critical role in this area in increasing disease awareness so that adherence to medicine becomes better, preventive health checkups become better, and there is a much healthier society that we are looking at than people who are actually giving up on their medicines. The other area that patient organizations can play a very critical role, and because they have large membership groups, is to create disease registries. We know that in Asia Pacific, we do not have clear disease registries in many disease conditions, and that does not help us to understand the burden of the disease or the cost of healthcare. And that could be the reason why many times countries are unwilling to invest in those specific therapy areas. So patient organizations can actually create these disease registries, or at least start the creation of these disease registries, so that there is some understanding of the burden of the disease in this particular area. They can also work with physician societies and other professional organizations to customize standard treatment protocols in the context of their countries. And let's be honest, some of those standard treatment protocols come from the more developed Western world with different healthcare systems, and sometimes are not really admissible or not easily adaptable to the Indian or the other healthcare systems of this region. So customizing them depending upon population needs would be something that patient organizations can work in partnership with the physician associations. Of course, the advocacy part is most important. Patient groups and patient organizations can work with their governments to bring treatments and diagnostics that are not available or available but out of reach of the common man, and work with the common man to be able to demand for that. They can create those advocacy environments so that the government listens to them, and they can bring in so much change within the healthcare system by contributing with the knowledge that patients bring that is unique to people with lived experience.
All right, Lance, what roles can a company like Roche play to foster patient engagement in diagnostic care?
Well, I think a great example is this conversation for a start. Elevating the conversation and the platform and getting the dialogue going is a key element. But I think another part is we need to continue to work hard in bringing solutions to the healthcare community that can be deployed in a patient-centric way. A great example is the self-sampling system that we have for HPV, for example, for cervical cancer. Now, frankly, I see this as a game changer, because if we talk about the cultural barriers that do exist around the world that we touched on earlier on, and also geographical barriers, for example, the fact that a woman can do a self-sample for a cervical screening test breaks down a lot of those barriers and means that for a cancer like cervical cancer, which is one of the few cancers that is absolutely manageable and treatable, we can address it, we know the causative agent, then this is a great example where Roche bringing the technology, the R&D horsepower that we have, to bear in a way in which the healthcare system and ultimately the patient can maximize the tools that are there. I think this is absolutely critical. And we've got some great examples of this. I think, in Australia, for example, the cervical screening program are rolling out self-sampling program there to reach women who do not have access in the major cities or don't have access to the labs directly. And then another great example is in Malaysia here, just next door, where Project Rose are using the self-sampling system along with digital tools to deliver the test result back to the patient themselves. I think they've screened in the order of 100,000 patients. So, you know, that changes the game.
Yes.
And that's the advantage of bringing the patient voice in.
All right, thank you for that. Dr. Devi, very quickly for you, on sustaining continuous patient engagement, could agencies like the WHO help to promote the acceptance of feedback from patients? Very quickly, please.
Most certainly, and I'm very happy to say that the process already started a couple of years back, where people with lived experience have been invited for regional as well as global consultations, and the feedback that has been gathered from these will be published in a report that will come out very soon. And this report will probably be a guidance document for the member countries of the World Health Organization to see and adapt how some of those recommendations can be used to bring the patient voice to the policy platforms as well as other discussion groups. Having said that, WHO just gives a guidance document. It is actually the countries that have to adapt it. And there is a lot of reluctance in many countries to recognize the patient as or the patient groups as giving something valuable that the countries can use. And I think a lot of advocacy needs to be done in this particular area where patient groups are accepted as a pillar that adds to better healthcare delivery mechanisms and the design and the implementation as well as delivery of healthcare. I think platforms like health technology groups, etc., are now trying to include the patient voice in it. But again, it is very patchy, and not all patient groups are at a level where they can contribute meaningfully, which brings us to building capacities of patients and patient groups. And many countries in this region do not do this in a proactive way. I think there could be some partnerships in this area where patient groups are helped to understand how they can contribute meaningfully so that their engagement is valued and the information and the experience that is given is used in a meaningful way.
All right, at this point, we have to take questions from the floor now. Let's tackle some of the ones that have been raised by our audience. First one for you, Lance. You're the first. Could health tech startups in the region play a part in patient engagement? What do you think?
Yes, I think they absolutely can. If you look at an organization like Roche, I mean, we connect and bring in a lot of innovation from the likes of startups and institutions who are doing innovative research. Now, I would suggest that research needs to have an eye on the patient. And again, often it doesn't, and that's not a criticism, it's just the fact that we're very scientifically oriented. And I think if in the early days of research development and a startup trying to bring a product to market, by delivering the need for the patient as part of that product design, absolutely valuable for the future if we can get this healthcare system to where we want it to be.
Okay. Dr. Suvanich, this one's for you. For stakeholders like the government or hospitals with limited budgets, what are some strategies to consider?
I think the health organizations need to identify the problem first, and then after we identify the problems, so they can set priority about the problem. Such as right now in Thailand, we enter about the aging society. So a lot of the people, they get cancer disease, diabetes disease, and there are heart disease. So if we have the limit of the budget, so we have to identify the problem first, and the funding about that treatments, about the cancer, about the heart disease, and then this can save the money, but can help a lot of the people.
Right, now to wrap up this discussion, a final question I have for all our panelists. What significant changes need to happen in the next 5 years to remedy the gaps in patient engagement? Dr. Suvanich, please start with this.
I think the first one is the technology. Right now, even right now, just can talk to you from the online, we are on the virtual. So this technology can use with the patient too. So the patient don't have to come into the hospital. We can talk together, we can discussion with the online. The telemedicine is very save the money, save the costs. And then you don't have to come into the hospital from the far from the city. So you can use the technology to contact with their doctor. So I think telemedication will going to be game changer in the next 5 minutes. Yes.
All right, Dr. Ratna, in a nutshell, please.
Yeah, I would agree that technology would be top of my list, not only for collecting the data and for helping governments to manage the cost of healthcare, but also from the patient aspect in accessing information, continuous monitoring, remote monitoring for people in remote areas or for very sick people, and using technology to advantage so that they're not traveling long distances to be able to reach a specialist. Telemedicine has been a game changer in the COVID era, where people were confined within their homes, yet were able to manage their healthcare well. So technology definitely, and the way communication and information is delivered. So we now see several methods by which healthcare messages are delivered, and that will hopefully improve the health literacy of people, making them want to be able to invest in primary health care and be able to manage their health better because there are no complications. And most importantly, point of care diagnostics and point of care treatment methodologies, which are bringing healthcare out of hospitals, the brick and mortar structures, to the communities, to the homes, so that people are able to access it much faster and much better.
Thank you. And finally, Lance?
Start with the basics. Let's talk to our patients. Get the true, honest patient view, and then we'll be able to deliver healthcare in a much more effective way. But I think, I just want to underline this. 47% of the world's population has little to no access to diagnostic tools. So that means half the world's population doesn't have access to the decision-making information that a clinician would need. The job at hand is huge. We have so much work that we have to do. So, I think everybody needs to really get serious about this in a sense. And I think bringing the patient's voice in will drive a much more nuanced healthcare delivery system and allow us to then build on the educational element. People need to understand the value of diagnostics. That would be my second point. So firstly, talk to the patient. Second point is understand the value of diagnostics and screening and staying healthy. And I think finally, somewhat of a pragmatic one, I think the regulatory environment for those of us that are operating in the area of health, delivering the tools into the system is a key area, working closely with our regulators and helping them move forward to be much more agile in their approach to making sure that good products and safe products are delivered, but importantly, understanding the role of digital tools, because digital tools are one of the key drivers that we are going to use to reshape healthcare systems with the patient in mind. So those would be my three elements.
All right, thank you. Do we have time for a question from the floor? Okay, there's one that's come in. Let's see. Which one? And how can we, this is for Dr. Ratna, how can we engage patients in a country where we do not have patient advocacy groups?
That's a fantastic question, because that's exactly what I do. So when I started working in this particular area, I found that there are many therapy areas where there might be one or two voices who were searching for information and therefore posted in blogs, etc. But there was no structured patient advocacy group happening. So we started to work with physician associations and with these one or two voices to create those patient groups. And it is a long, arduous journey, but the outcome is extremely fulfilling. It takes little time and patience, but once these groups form, they actually get a life of their own. And then they start to demand and they start to work together to be able to search for the answers that they are looking for. And that brings a tremendous change in the system. also in this very connected world, once you start a patient group in one country and they start posting on social media, automatically people from other parts of the region start joining in and it becomes a movement. So I think it was not such a big challenge not having a patient group, as long as there is someone interested to start that and invest the time and resources that are required to make it live and functional.
All right, thank you for that, Dr. Rana. And panelists, thank you for your time, for your insights. In 15 minutes' time, we'll come up with our next panel discussion. And on that, we'll be talking about labs of the future. I'll see you shortly.
Artlist.io. Music licensing reimagined. Artlist.io. Artlist.io. Music licensing reimagined. Artlist.io. Music licensing reimagined. Artlist.io. Artlist.io. Music licensing reimagined. Artlist.io. Music licensing reimagined. Artlist.io. Artlist.io. Music licensing reimagined. Artlist.io. Music licensing reimagined. Artlist.io. Artlist.io. Music licensing reimagined. Artlist.io. Music licensing reimagined. Artlist.io. Artlist.io. Music licensing reimagined. Artlist.io. Music licensing reimagined. Artlist.io. Artlist.io. Music licensing reimagined. Artlist.io. Music licensing reimagined. Artlist.io. Artlist.io. Music licensing reimagined. Artlist.io. Music licensing reimagined.
Hello, everyone. And for those you still with us since the last discussion, welcome back. I'm Genevieve Wu of CNA, and this is the second panel discussion from the Diagnostics Media Forum hosted by Roche. With us are three speakers to share their knowledge on the topic of labs of the future and the role of these labs as enablers of patient-centered care. Now, in particular, we'll be focusing on labs in the Asia-Pacific that screen for, detect, and monitor services, otherwise referred to as diagnostic tests. Now, to discuss if labs could become a foundational element of patient care, I have with me Dr. Dewi Mulyati. She's the President Director of PT Prodia Widya Husada. Among other services, her company in Indonesia also sets up and manages health laboratories. Dr. Dewi.
Hi, Genevieve.
Welcome.
Yeah.
And our virtual panelists from Melbourne, Australia, we have Dr. Robert Grenfell, a public health specialist who is the Chief Strategy and Regions Officer for Grampians Health. He's done work in nutrition, e-health, medtech, diagnostics, and biosecurity. Welcome, Dr. Grenfell.
Yeah, good afternoon, Jen.
Hi. And joining us from India is Dr. Kuldip Singh Sachdewa, a chest and tuberculosis specialist. He's also the Regional Director for Southeast Asia for the National Union Against Tuberculosis and Lung Disease. Hello, Dr. Sachdeva.
Good afternoon, Jan.
Hello. And a reminder to the audience, you will have a chance to pose questions to the panelists as well. You can send them in using the Q&A box below. Over the course of the discussion, we'll get our panelists to answer selected questions. Getting to it, in the battle with COVID-19, testing and diagnostics became more important. What was happening only in labs came into the spotlight with the introduction of rapid antigen self-test kits. Things became not only DIY, they also became decentralized and digitalized. Some of you probably received on your smartphones the results of the polymerase chain reaction or PCR tests done at the labs. Now, Dr. Dewi, with digitalizations, how has labs and lab testing changed?
Yeah, digitalization enhance the accessibility for patients to the labs. Yeah, they can directly register for lab testing and select the kind of test and also pay through the apps. Yeah, then they can make teleconsultation with doctors. With this easier way to get service through digital platform, adopting a patient-centric model is more possible now than before. Yeah, digital technology can support customer-centric model, then more personalized to us. Yeah. Even healthy patients, they can also get the testing from this platform. Yeah, of course, the sick people, they can also get the testing from the apps. Yeah, so the patient can active participatory to get testing as they need.
Mm-hmm. Now, speaking of patient-centric, like you mentioned earlier, not being healthcare experts, patients not being experts, can patients oversubscribe for tests, or ask for tests that they don't need?
Yeah, that is important of education and information. Patient can get information for many sources. Yeah, a lot of information they can get from social media, public webinar. They should have correct information from a good lab provider, so they can select the appropriate test they need. And also the lab provider, they can limit the tests provide only for health checkup and disease management. So with that, once they get abnormal result, they can consult, come and see doctor.
I see. All right. Dr. Sachdewa, how are patients' expectations and the doctor-patient relationship evolving with regards to diagnostics?
And these are two different questions. So I'll first address the patient expectations. Patient expectation is also a subset of the context in which the patient is and the experience the patient is going through. If the patient is not well or sick, he sees a medical practitioner. Then the practitioner will prescribe him certain tests. Based on those tests, they will go through the testing procedure. So if they are happy with practitioners, the way they have been, he has elicited their patient's history, he has examined them, thought through their illness, discussed with them and prescribed certain tests, they are happy about it. If not, then they start sort of doubting the clinical skill set of the physician, and they like to go to a different clinician and say whether that clinician also prescribes a given set of investigations or not. That's one set. The other is whether they have been prescribed by themselves. In our country, self-prescription is also very common. Patients generally go for a preventive health checkup, which even doctors advise. So they go for a preventive health checkup, that's their own decision, so they are happy with whatever the results come. The another is that patient is on treatment for a certain disease and they want to follow that treatment. Say the patient is on treatment for diabetes. Now he wants to regularly follow its blood sugar level. So they can go on their own or they can be prescribed their physicians. If the blood sugar levels are matching with their treatment and they are in control, they are happy. If they are not matching, then again they see a physician and get the necessary medications altered. That's another set of conditions. The third is where patients look for validation. The physician has prescribed some sort of tests, and they may have a feeling that they have been overprescribed or underprescribed. So they may, or the tests, they turned around the results by the laboratory may not be quality assured. They may question those tests. So they may like to get validation from another lab, whether the results match or not match. So that's the, in brief, about patient expectations. On doctor-patient relationship, it's evolving over years, and it's also evolving as the industry is growing, as the diagnostics are maturing, and more diagnostics are becoming available, and patients and both physicians and patients now have a choice for a rational diagnosis, which is well thought through. So initially, when there was no diagnostic, it was more, the relationship was more on trust and faith. With the diagnostics becoming available, then the relationship was still on trust and faith, but then slowly and slowly they started questioning that whether the prescription is rational or it has been over-prescribed. Subsequently, with in our country especially, the healthcare was declared as a service, as for any other service, and that started changing the contours of a doctor-patient relationship. So now you pay a fee for a service and you get the service. That relationship of trust and faith started slightly evolving, or then you are more questioning, more critical of the skill set of your doctors and physicians. And then with the healthcare being declared as an industry with a motive of profitability, now they are sort of very critical about what they are prescribed. And you asked an earlier question, can patient oversubscribe? Similarly, even doctors can oversubscribe the test results. So that's also changing the doctor-patient relationship. Now they are more critical of the skill set of their physicians, and they'll to evaluate by themselves. And now with so much of information being available on web-based platforms, they evaluate more. So that's how the relationship is evolving over time.
Right, thank you. Dr. Grenfell, what's the major challenge for patients with getting lab tests that they need? And should patients or even clinicians rethink their perspectives on lab tests?
Yeah, so there's a lot of what I would call patient-focused barriers to access. So one of those is price or cost and the ability to afford those. The other one is the health literacy level that they may have. Do they understand why they're getting a test? And so one of the frustrations for lots of clinicians is that patients, they may order a test for them. The patient may not get it done because they don't understand the importance of doing that. So cost and accessibility is one, and accessibility, particularly for the frail, the aged, or the disabled, is and also those that are living in remote areas, is actually getting to where they may well be getting a test done in the lab. So care testing's got a lot of advantage in that setting. The other one, as was pointed out by our colleague in India, is the knowledge and the skills of the clinician themselves as to what tests are actually available, because this is a rapidly evolving area with regards to new technologies coming through, and keeping up to date is a challenge. So getting that access for patients is one of actually getting the clinicians to actually know about organising them too and arranging for those. And then the other one that's a frustration, I think, for a lot of manufacturers of tests and distributors of those is getting through the regulatory system. That is a barrier or a challenge, in fact, for getting accessibility for testing as well. So there's multiple layers there, Jen, in getting through to tests for patients that all have to be addressed for everything to work perfectly.
So on the point of accessibility, Dr. Sachdeva, would the decentralization of labs make the patient's journey more convenient?
So on the point of accessibility, there's nothing like if you can have this available at your doorsteps. That's the ultimate dream, the ultimate aim, which policymakers and all those who think of public good would aspire for. Having said that, there are pro and con on both sides of centralized versus decentralized system. While some of the tests can be decentralized, the best example is point-of-care diagnostics, which can be decentralized to the most peripheral level. Some cannot be decentralized. Also, you have to see decentralization as a concept. If you cannot move a sophisticated laboratory to a periphery, you can move samples to a sophisticated laboratory. So that's as good as decentralization being made available from the patient point of view. So when you make samples, you collect samples, and then when you transport those samples to the centralized lab, to be that the decentralization of laboratory services. Also, you can sort of move patients or subsidize their travel, which most governments and public health programs are trying to do. If you cannot transport samples, patient has to move, then you compensate for their costs of movement and their wages loss. So that's also partly covers for their expenses, and as good as being decentralized here, because you get compensated for whatever you lose on economic costs. So that's the other concept of this. Having said that, sometimes centralization for sophisticated tests, which are not possible to be placed everywhere, they are very costly tests, or the number of tests to be conducted in a peripheral setting may be too low. So you need, in that case, you will need a centralized services for that. So these are few thoughts, but nothing like decentralization. That should be the ultimate aim of any policymakers. Maybe labs have to think through how, and even in a notional sense, they have to make them available to the patients at their doorsteps.
Right, thank you for that. Now, on to another theme. Now, routine screenings don't necessarily have to lead to an immediate diagnosis of a disease, but could help prevent its onset. So let's explore how labs can transform to have the patient at the core of preventive and also personalized care. Dr. Sachdeva, maybe you can start off on this. In a large Asian country like India, what's the level of public interest in preventive care?
So it depends. See, few things in preventive care are very well internalized. Say immunization. We are not questioning immunization as a preventive thing. Everybody, once you get a new birth in your house, you get all your parents are ready to get that child immunized for all the vaccine preventable diseases. So that's very well internalized. But few things are not internalized in preventive care, which is, say, safety and hygiene. In COVID also, we realized that what we practiced during COVID was not our habit or behavior. So those aspects of prevention were not very well internalized. But preventive care slowly is getting internalized thanks to a lot of health literacy Dr. Krefel was referring to, also to a lot of advocacy by policymakers, labs, doctors, medical professionals that you need to screen for disease. That is where concept of preventive health checkup is getting very popular, and it's getting traction in the community. It's not there for everybody, but even public health programs are also sort of promoting preventive treatment much more than a treatment per se for disease. So chemoprophylaxis or preventive tests so that detect something or diagnose something and take a corrective action in that. So a lot of that is getting traction lately, and I think it's there to stay.
Right. Dr. Dewi, now your company operates health laboratories. So apart from technological changes, how else must lab operations evolve, right? So that labs can anticipate and prevent future health crises?
Yes, thank you. Before COVID-19, we consider cost, quality, and service as our important things when we manage the lab. Yeah. And now we have other considerations, yeah, how to be agile, more flexible and adaptive. Not just adaptive, but also how to anticipate a situation. Yeah. Labs now are struggling with costs because of supply chain disruption due to geopolitical situation. So the extra considerations are needed to us to be resilient. Yeah. And digital information support lab service and their support system to improve the cost, the efficiency. So our labs are gathering more information from manufacturer, regulators, from media, from journals, articles, so that we can use this information for our risk management, yeah, and also the cybersecurity risk to protect patients' data and labs data. Prior the pandemic, yeah, we use the same template for perhaps 3 to 5 years. Now we have to revisit every time how to use the risk factor as risk management.
Okay. So speaking of management now, patients' needs are always changing now,
yeah,
right, Dr. Dewi? How should labs reinvent their role?
Yeah, it's important to innovate, to create the new things, yeah, include the new testing, new packets for patient outcomes, and also increase the clinical benefit for patients and health doctors. Yeah. And also how to translate the research data to the service. Yeah. For example, many pharmaceutical companies, yeah, they discover targeted therapy. It's kind of precision medicine for cancer. Yeah. Then when doctors deliver this therapy, the targeted therapy, they need testing to know the mutation type of the cancer. This innovation can help patient to manage or to treat their disease. So the traditional testing, like bread and butter tests, still needed to support more to support precision medicine, personalized medicine for more difficult disease. So now also people focus more to climate change, sustainability.
Yeah.
Yeah. We're looking into a solution, how we manage our lab waste as part of our environment responsibility.
Yep.
So with our best practice, we have to save our environment. Mm-hmm. And labs now are not just thinking about the growth margin for business sustainability, but also the environment sustainability and also our social responsibility.
Okay. Right. Dr. Sachdewa, picking up on Dr. Dewi's point on how labs need to be innovative, right? Innovations have provided labs with the ability to work with big data. Now, with the application of big data in molecular diagnostics, is there potential for more personalized medicine?
So again, the definition of personalized medicine will differ from clinician to clinician. What I call as a personalized medicine is when you are treating the disease as per the patient needs. Say molecular diagnostics are a boon currently. You can diagnose the specific targets which need to be You can identify specific targets and treat them accordingly. You can also sort of change your treatment according to those targeted results. So it's helping the programs and the clinicians in a big way to offer those personalized services. But what is generally understood by medical community as a personalized service is what Devi was referring to, which is targeted sequencing, where you actually look at the genome sequencing and then sort of offer therapy which is too individualized for a patient, which is currently being developed for cancer treatment, specifically for lung cancers, many other cancers. You are offering very, very personalized treatment based upon their gene sequencing and where those mutations are occurring. So I'm going a step lower than that. Say we do susceptibility testing. That's also sort of a testing where you know to which drug you are responding to. Say if you're responding to a drug A, you offer drug A. If you're resistant to a drug B, then you don't give that drug B. And that's being practiced in many fields of medicine currently now, which is most infections, you do a drug susceptibility testing and then offer a treatment which is best suited for the patient. So that's also a personalized medicine to as per a common understanding or understanding from the patient point of view. A huge help in this is given by big data analytics because these sequences run into millions and millions. So possibilities are enormous, and big data analytics helps us to make sense of those possibilities.
All right. Now let's turn how to discuss how current labs could evolve so that they may deliver more successfully on their potential. Now, Dr. Grenfell, when you think about the labs of the future, what is it that you imagine?
So I certainly imagine that they're not actually like what they are now. The idea of bricks and mortar laboratory will still have a place because there are many tests that will still need to be performed in that laboratory setting. But so many things can be moved out of that laboratory setting and moved closer into the clinical space or even into the personal space right directly in the hands of the patient. So what's the connecting point here? It's actually the data that's coming from those results. So the future lab is one that actually is a data collector, a data collator, and producing dashboards that actually come back to the patient and the clinician on where that person is in that particular time. So I guess in one sense, I've often said that I view that pathology services are at a sort of a Kodak moment where they're going to have a rapid digitisation of what their product is and moving into that space where in real time, or at least in data aggregated times, they're looking at something that's actually more pertinent and more direct towards what the clinician needs and wants, and also a greater representation of what's happening with the patient at this time. So big changes afoot, and feed into that other data sets as well, such as particularly digital feeds for a number of other parameters that could be measured, such as simple things like weight and blood pressure, which are extremely helpful in managing, say, chronic diseases like heart disease and others. Combining those in with some of the pathology metrics and measures, both tested outside of the patient or in the hands of a clinician, are in fact actually going to offer an enormous amount of value in both self-management and also clinician titration of medications and other things. So a very exciting time. And I think that for the bricks and mortar pathology companies, really start thinking about how can I take my business into this next stage, because it's coming.
Dr. Sachdeva, with patients' needs at the core, how do you envision labs of the future?
So some of it Dr. Grenfell has already talked about. For me, labs of the future is something which patient can do themselves at their homes. Say pregnancy tests, you don't need to go to a lab. So that's the ultimate aim which labs should aim for, the test which can be done just at your bedside or at your home and can deliver your results. I understand that's not possible for each and every test, but then the next step would be as close as to the patient. If patient cannot do it, then a healthcare worker with minimal training should be able to do it. So you don't need a lot of expertise to do it. It's within that will fall automated tests which are available on your bedside. So from your house next to your bedside. If you can have labs which can deliver results on your bedside, that's excellent. A further step would be as close to your residence as possible. So labs of the future should also look at tests which are more non-invasive. The sample can also be more non-invasive. So more research, innovation in what should be a sample should be. If a body fluid is saliva and urine can be collected, nothing like it. The next simpler is if you can collect blood, that's nothing like it. But if you have to get tissues and other samples to diagnose a test, then that should not be what labs of the future should strive for. Ideal would be you just scan through a patient and that gives you a complete profile of that patient. So as simple and as closer to the patient they can get, that should be the idea of labs of the future, and there needs to be a huge research, and actually we are moving in that direction with point of care diagnostics, bedside tests, ELISAs, etc. So we are somewhere moving in that direction.
Dr. Grenfell, still on the future of labs, do the labs in the Asia-Pacific region now possess the infrastructure to further unlock the future of labs? Are they connected or integrated enough?
That's an excellent question, and I guess the simplest answer to that is no. But there are great building blocks for actually moving forward on this. So think of the data problem in the first instance. We have the issue of interconnection between our data sets and the various ways that we actually transmit our data. We have the privacy issues that are actually needed and the security issues needed for actually doing those data parts in there. The next is workforce. Where we do need laboratory staff, we actually do need to have workforce across our region, and that's a problem that we all face with regards to having the appropriate ones and workforce in the right place. The other one is the expansion of, particularly as both myself and Dr. Sachdev have talked about, of having healthcare workers able to administer, say, point-of-care tests or bedside tests, and having that skill set. And one of the toughest challenges in healthcare is actually changing the way that the existing clinicians behave and actually administer their work, and getting them to take on a new way of doing things. That's always a big challenge, and that is not to be underestimated where it is. And across the other one, if we look at the more systematic challenge, is the challenge that all countries have different regulatory systems. And we have to actually go through to actually validate the usage of those within our systems, and then also the payment structures that actually occur across these areas. So it might sound a Herculean task. However, let's be positive about this, Jen. I reckon that if we could move towards supporting all of our countries across this area, we might save a lot of cost for those countries that get invested in a lot of the infrastructure in pathology to in fact provide that across the region, which means that we'll be taking a lot of healthcare and new healthcare to as many people as possible across our region, which is certainly a noble cause and something that we as health professionals would be extremely excited about progressing with. So there's a lot of partnership here. There's also a lot of challenges, and I think don't underestimate them, but certainly don't let them stop you from doing what you actually need to do to actually get this care out to people.
Right. Dr. Devi, for labs in Asia to reach new heights, can labs do it alone to achieve this outcome?
Yes, it's an interesting question. Yeah, laboratories now, I think we will have to be supported by many stakeholders. Yeah. I consider 3 C's for this: coordination, cooperation, and collaborations. Manufacturers, vendors, and also distributors can provide more efficient pricing for labs. Yeah, the automated system and also the instrumentation technology can support us to minimize the volume of chemical, reduce cost, and reduce waste, yeah, as I mentioned before. So supply management also can be supported by manufacturers and vendors to be faster and available every time. Yeah, as you know, as we face the supply chains disruption. So support from regulators also in terms of regulation and license is important for a patient-centric model. like we discussed today. And also, I will share with you my labs with certification and accreditation from CAP, College of American Pathologists, and also ISO 15189. That require us to use high quality raw materials or reagents, so mainly from the West. Yeah. Now we see in the market there are a lot of reagents, raw materials from Eastern countries with relatively high quality but with low cost. So this is our competition in the market. So how we deliver the service with more affordable, like Dr. Grendel said, but with still the best quality. Yeah. So I think the Western manufacturers, they also have to consider how to match the price in this situation.
Okay. Dr. Grenfell, now are labs changing their manner of operations significantly enough to take us closer to the future of labs that you've envisioned?
I think I'm frustrated a little by the progress of change, but I don't think we can blame the laboratories completely for this. There are perverse drivers. So as has been mentioned, is the payment structures for doing tests still favours the old model, and it depends on whether the reimbursement is from a government-sponsored health system or from a private insurance model, or in fact actually from a patient-driven area. It's a matter of what's the price incentive of how your actually lab behaves. On the second part of that is the workforce that the laboratories have got, are they actually pitched to work in this new model and in the new way that we in fact actually are needing this type. We had some certainly challenges here in Australia with point-of-care testing, for instance, introduction in COVID, for that matter, and that was really an issue of actually not necessarily having the systems that were ready to move for point-of-care testing and the collation of the data. And you might find that rather alarming and challenging, but let's think about home monitoring for blood glucose. I'm now a 30 years long health professional, and in my time it's gone from the GP doing the blood sugar to now a child being able to do it autonomously even in their classroom. But think about how long it's taken, Jen, I mean, in the sense to move to that, but the miraculous control that's occurred there. Well, pregnancy tests, for that matter, was something that a doctor used to do 30 years ago in their consulting suite, but now a patient's actually entrusted to do that. What we're missing in the pathology industry is the connection of that point-of-care lab result into the data system. And we know that there are many of these ways of doing that. So that's one big step. That yes, let's take the test to the patient, but please let's collect the data from that so that it actually can be presented in a collated manner. So where are the labs? The thinking about your finance models, the thinking about the way that you could change and pivot your business to be very patient-centric and to actually adopt this, this new manner of care that actually is rapidly approaching us.
Right. Dr. Dewi, now earlier you had mentioned the 3 C's, right? You talked about collaboration, coordination, and cooperation. How has technology enabled that to be realized?
Yes, digitalization has enabled data sharing. So with this, we can connect with others through digitalization. Yeah. For example, Prodia has referral labs across Indonesia. We have 4 laboratories in different main Indonesian islands in Jakarta, Surabaya, Makassar, and Medan. So we operate with the hub and spoke models. Yeah. But the interfacing, it's not only for hub and spoke model, but also important for the lab operation, in the lab operation. So the instrumentation, all the link from the patient admission to specimen preparation and sample collection to the instrumentation through the barcode from data patient and also kind of test. Yeah. And those all integrated on the systems allow the laboratory deliver the test result faster. Yeah. And as lab, we also build the interoperability between us and our customer, yeah, to hospital labs and also clinics, doctors, insurance, and other customers, B2B customers. So as long as they share the API, we can connect each other. So I think digitalization can connect us with the concept of 3Cs.
Okay, cool. Dr. Grenfell, how can disruption happen? Seems it's not just a case of healthcare providers alone getting on board, is it?
No, it's certainly not. We need to be looking at, I guess in one sense, what are we trying to achieve in the first sense? So we need to have the common goal of how are we actually trying to achieve the healthcare and what's possible. So by keeping the patient at the centre of what we're actually trying to achieve, we can in fact actually consider how can we make things more accessible for them? How can we partner and collaborate with the patient on in fact doing this? How can we actually work with them to understand what it is we're trying to achieve? Because often you'll find the clinician's objectives are a little different than the patient's objectives if you haven't agreed with that. The other part with the innovation, as I mentioned before, was what I call clinical inertia. It classically takes about 15 years, unfortunately, to get new innovation into clinical practice. And the barriers that actually cause that are actually quite complex. What are the reasons for the clinician to change the way they do it? How actually can they fit that into the way that they provide their care that's acceptable to them in that area? And the other one that was mentioned as well is cost, because when we actually take a lot of new things, new therapies, new diagnostics, they actually do cost a lot of money. And how we actually might bring those in. The speed can be limited by some of those. The other one is the will. And I think, Jen, that's the idea of actually for us from manufacturers, from producers of tests, and also from the healthcare system is to actually say, right, we need to change how we're doing things. I'll give you an example. For instance, here in Australia, like many places around the world, we're having incredible trouble attracting workforce to a lot of our public hospital systems. And that, of course, puts a lot of challenges and strains. So we have to do things differently to actually provide the care. And part of that is increasing and strengthening the partnership with patients and looking at new and innovative ways to deliver that care that gives control to the patient in the sense of how their care will be directed, and also allowing clinicians to see larger numbers of patients safely and in a quality framework. So you can sort of see it's a very challenging future we're moving into, and I know that many countries have the same problems that we do with regards to this. So it will be interesting, but I do think leadership is one of those things that we need to look at from our sector and industry, and certainly you're one of those leaders. So the issue is, how do you in fact actually enthuse your fellow clinicians to actually move in this area?
All right. And now let's turn to some of the questions raised by our virtual audience. One question for Dr. Sachdewa. Are labs getting the support they need from different stakeholders to transform their services for patients?
The answer to that will be both yes and no, because stakeholders, all of us are directly or indirectly stakeholders for labs, or in what I'm trying to say, we are stakeholders for a common public good. So patients, of course, they want the best tests which can diagnose them very easily. So patients are the most important stakeholders. Then the next is their immediate relatives, the community, that's an important stakeholders. So they do get support from that. But what support they need is actually from the policymakers, the governments, the insurance companies, who are again very important stakeholders. So some diseases of public health importance do get support from policymakers, government. So like We have various public health programs for tuberculosis control, for HIV/AIDS control, for vector-borne diseases control, and so on and so forth. So, but not everything gets a support from policymakers. Some of which are, say, rare diseases, they still need the attention. You have to get that attention from the policymakers and stakeholders. Industry, academia, researchers are again very important stakeholders, and they need to actually work for diseases which are both common and also for uncommon diseases. So researchers are very important stakeholders, but I don't think that we are getting enough funding for research to actually develop new novel tests for that matter. So the stakeholders are innumerable, and we do get support from some, not at all from some, and some mixed level of support from other people. But I think it's a continuous advocacy efforts which need to be sustained, and we must keep on moving.
Right. And to wrap things up now, this is my final question to the panel. What are some of the steps that different stakeholders in the Asia-Pacific region that they must take, right, to strengthen labs in the role that they play to shape healthcare in the next 5 years? Dr. Grenfell, can you kick this off?
Okay, so certainly digitization and understanding the value of digital transformation, that is the most important one. How will I receive the data that will be coming in? So as we move more and more tests out of our laboratory, will I be bringing that in safely, securely, and then feeding back to the relevant clinician or patient the analysis of that data? That would be the most important step that needs to be taken, because the exciting tests and new technologies that are coming in with particularly the proteomics and everything else, is we are going to be able to measure a lot of things in the future. So get the data sets ready for revolution is my advice, Jen.
Thank you. Dr. Sachdeva.
So the best step any government policymakers or they can take to support is to make these affordable or free to the patient. So a lot of steps to develop your insurance industry, whether it's government insurance or private insurance, so that patients are covered for those costs, whether the tests are cheap or whether they are affordable or not affordable. If patients are covered, that's the best step you can take to make them affordable. And the next step is encourage research, encourage academia, encourage industry to innovate, come out with newer tests which are more sensitive specific, come out with point of care tests as decentralized as possible. So that's the next step, which again, government, academia, philanthropists, industries, they all must take to make them again closer to the patients, as simple as possible and as freely available as they can be.
Dr. Debbie, your thoughts?
Yeah. Labs now cannot stick to the same as 10 years before. Yeah. So we have to change from the traditional manual procedure to digitalization. So digitalize all the lab do. How we manage data, yeah, we talk about the patient-centric model and also innovation. Yeah. With this, we obtain a big data. Yeah. So we have to increase our capability to for data analytics. So it is important for us to know patients' need, doctors' need, customers' need through the data analytics. In terms of customer relation, we know about the CRM. So for all of this, I think digital transformation, digitalize all the things do in the laboratory is important.
All right, thank you. And a big thank you to our panelists all for your insights today, and also to our virtual audience for taking time. And we hope you took something away with you to chew on. And until we meet again, I'm Genevieve Wu of CNA, and on behalf of our panelists here, we wish you good health.